Welcome friends to our NPTEL MOOC module on health economics. We are in the final week where our focus is on the healthcare provisioning and their responsiveness, and which leads to the understanding of public health. So, the responsiveness etc., the health system etc., are the focus of this unit. So, in the previous lecture in particular, we discussed about public health, their definition and their function, the core activities and the ethical issues. Here, we will be emphasizing on health system responsiveness, and hence we are addressing healthcare provisioning and health system responsiveness. Under the following will be discussed step by step on components of HSR and demand and supply side impacts. Then what do you mean by health provisioning? We have to refer to the standard work of WHO of 2016. It states that all services pertaining to illness, diagnosis and treatment or the promotion, maintenance and restoration of health are the part of the category of healthcare provisioning. This includes both personal and non-personal health services. While in particular focusing on provision, it refers to how resources like cash, personnel, supplies and medications are brought together to enable the delivery of medical interventions as mentioned in the same work of WHO 2016. Hence, healthcare provisioning refers to the planning, organization's delivery of healthcare services to meet the health needs of individual and communities. This encompasses a broad range of activities such as establishment of healthcare facilities, deployment of healthcare professionals, development of healthcare policies, then their management of the resources which will ensure the effective and equitable delivery of healthcare services. One thing is important to note that collaboration amongst a range of stakeholders including government organizations, healthcare providers, insurers, academic institutions and the community is indeed necessary for the effective provisioning of healthcare. The key component of healthcare provisioning hence also includes the stakeholders such as healthcare professionals, policy, regulations, information systems, workforce development as well as the community engagement for the health promotion. Then what do you mean by healthcare facilities? This includes clinics, health centers, hospitals, specialized centers. To specify a few, like in hospitals, we need to also take care of emergency care, surgeries, specialized treatment. About clinics and health centers, it includes PHC primary care services at the PHC level, preventive care and basic diagnosis and treatment services. These are more accessible to communities and play a important role in promoting health and preventing diseases. Specialized centers focus on specific areas of health care such as mental health clinics, rehabilitation centers, specialized clinics for chronic diseases. So, about healthcare professionals which is part of the healthcare provisioning, it includes physicians, surgeons, nurses, administrative staff and allied health professionals as well. So, health information system includes electronic health records, master facility list and health information exchange. Healthcare policies and regulations are important, this is pertaining to financing as well, which includes health insurance, public funding, reimbursement mechanism etc. Quality assurance is another aspect of this provisioning which is also part of the healthcare policies and regulation. This includes implementation of standards and protocols to ensure the quality and safety of healthcare services. Another aspect is called regulatory framework. This encompasses laws and regulations that governs the practice of healthcare professionals, the operation of healthcare facilities and the overall healthcare system. So, as I already mentioned, the community engagement is also another pertinent aspect of health provisioning. This includes PHC campaign, the health campaigns, including public health campaigns to promote healthy behavior, prevent disease, educate the public on health related issues, community outreach, such as programs that engage with communities to understand their healthcare needs and address health disparities. Workforce development, including training and education, like health related educations and health related professional and their trainings will enable skills to maintain the standard of the healthcare provisioning. Then including workforce planning and management, that includes strategic planning which will ensure adequate and appropriately skilled healthcare workforce. So, healthcare technology, that includes medical equipment. It has a provision for acquisition and maintenance of medical devices, equipment used in diagnosis, treatment and patient care. Telemedicine, this provides healthcare services remotely, including access to care using a cell phone or even tab, mobile, through internet. Some of the examples like 1mg, like Practo. Okay, so there are n number of such examples across the globe. The goal of healthcare provisioning is to ensure that health services are accessible, affordable, with better quality or high quality, and that should be responsive enough to the diverse need of the people. But in reality, these expectations are compromised in some of the cases. Hence, we need to unfold the cases of healthcare with reference to India at this moment. So, as per the latest micro large scale information based on the survey from the household, which was conducted by National Sample Survey in its 75th round, which was in 2017-18, which emphasizes the treatment of the ailments based on short run and long run ailments with 15 days and 365 days cases. Government hospitals, in case of 30% ailment, this has and in private hospital in case of 23% of ailments. So, these are the facts derived from the NSS 75th round. Private doctors and clinics in case of 43 ailments are actually accessed. Informal healthcare providers and charitable trust NGO run hospitals in case of the remaining 44.1%. Another, these are OPDs, outpatient cases, outpatient department order treatment. Inpatient hospitalization cases excluding childbirth are also recorded, like public hospitals accounted for 42%, private hospitals also accounted for more than that. Hence, the out-of-pocket expenditure is also higher. Then charitable or trust NGO run hospitals account for 2.7%. Population with health expenditure coverage, like 14% of the rural population and 19% of the urban populations is covered as per the health expenditure is concerned. 13% of the rural and 9% of the urban population covered by government sponsored health insurance, 1% of rural and 6% urban covered by health insurance arranged by government PSUs as employer and employer supported health protection schemes. 4% of urban population covered by health insurance arranged by households with insurance companies. Average medical expenditure per hospitalization case as per the NSS 75th round, like rural India about rupees 16,676 and rupees 26,475 in urban India. That is average medical expenditure per hospitalization. You can refer to also national health accounts 2019 figure as well, which is the latest, and the government public hospitals and accountable for the average medical expenditure, that is of rupees 4,452 on the aggregate, which is of 4,290 in rural and 4,837 in urban areas. Okay. Private hospital and their expenditure was about 31,845 rupees and rural and urban decompositions are mentioned, we are directly referring to the official data. The high proportion of out of pocket expenditure OP in private care is the consequence of the effect of lack of public health provisioning. Okay, so it is to be noted that this lack is actually resulting higher burden on the households. Due to this, private sector act as the main provider of health services with lack of proper regulation of prices and services. To pay for inpatient care, more than 64% of rural households and 40% urban households with hospitalized cases borrow their money or sell assets, rely on donations from friends, family, as Joe 2015 work highlighted. To improve the access, affordability and accessibility of services and health seeking behavior towards the public provisioning or public care, health systems should be accountable and should be highly responsive and efficient enough. Hence, it directs to the understanding of HSR, health system responsiveness. What is this all about? It is explaining a system, a health system which has a certain level of responsibility to the non-health expectations of the people. So, it is to be emphasized that the health system responsiveness is actually accounting for non-health expectations of the people. Okay, so it is not directly to the treatment, it has to be directly addressing the non-health expectations. According to WHO 2000 report, the non-health expectations of the people has 8 domains. Okay, so like dignity, autonomy, confidentiality, prompt action, quality of amenities, clarity of communication or information, choice of providers and access to social support networks. So, you can note that these are not directly linked to the health requirements. These are beyond health, hence it is mentioned non-health expectations. So, dignity, this refers to the experience of the patients or individuals of being treated respectfully and their privacy is indeed respected. Regarding autonomy, it has to be the freedom, the experience of the patients being involved in making decisions for their treatment. Like a large proportion of people were not always provided with various treatment options. So, treatment options should be provided to decide to have their decisions. Hence, patient acceptability is used to be a question in Indian health system. So, autonomy really matters. Healthcare providers have neither been prioritizing providing treatment options nor asking for their acceptability. To note here that the training and orientation of the healthcare providers are required, which is must in this direction, that will prioritize the patient to seek their treatment, and that will also to a large extent minimize their out of pocket expenditure. Regarding confidentiality, another important aspect of the health system responsiveness, it includes factors related to secrecy, information shared by the patients or individual with providers kept secret or not. So, that is creating confidence on the healthcare access. This includes private space for the patients to be able to talk privately to the providers. Another is called prompt attention, how quickly the issues is addressed, including waiting time, time to reach hospital facility, mode of transport. You might have heard that in the developed countries they have a dedicated line for the ambulance service and the emergency transport services to have a quick connect of these access. So, a public policy discussion must be focusing on a dedicated line. Okay, even if our population is huge, but it can be greatly the chaos can be greatly managed. So, waiting time is important. We discussed patient travel, as we all witness that from a far flung area till reaching to the place, really is a cumbersome process and they indirectly incur huge cost. Patients with no out of pocket expenditure for transport to reach the hospitality is required, hence the patient will be highly satisfied. Quality of amenities, how far the quality and functionality of the amenities is also important, such as cleanliness, even nearby the waiting area like toilets, availability of drinking water, seating capacity. Then clarity of communication and information, which is provided by the providers to the patient. You might have heard that the patient is from a rural area or from different region having a different language. Since we have huge number of languages, the patient may not able to actually express correctly. Hence, the health system must be geared enough, must be trained enough to be capable of understanding the communication of the patient. Okay, so they should listen carefully, clearly, and they must understand, especially to cater to the need of the patient. The choice of the providers, as already said, to a large extent we discuss about autonomy, and maybe overlapping with that. Access to a social, in case of choice, this investigates whether patient or individuals are able to see a healthcare provider of their own choice. Okay, so this is what to be emphasized. Then another one is called the social support network, prominently related to inpatient care, but is also valid for outpatient care. This allows your family members or the relative that used to have huge confidence on the mind of the patient who are already hospitalized. So, as mentioned here that WHO work of 2000, the recent literature finds that trust on the doctors and provider are also very important factor which dominates the responsiveness. So, you can also relate to in the remote areas and the villages, people rely, since the health system is not that good or not that trustworthy or maybe lacking in many indicators. Hence, those far flung areas, especially villages and remote areas, that depend still on the quacks and the jharpuks and the traditional home based medicines. Okay. So, even if those are not clinically proven, but still people are dependent on it. So, coming to HSR, once again this improves the access and acceptability, and to improve access and accessibility, the acquisition of knowledge, self efficacy, attitudes, health behavior are important, and hence the health literacy really matters. Health literacy of the health provider as well as the patient, but most importantly the health providers. Health literacy refers to the capacity to acquire, process and understand healthcare information and services required to make suitable decisions related to wellness and patient care. Hence, to present it in a structured format of the HSR, we have supply side and demand side aspect. In the agents on the supply sides are important, like political leaders, policymakers, managers, service providers, etc. This helps in efficient and proper functioning. Whereas, we have a demand side as well. However, the agents of the supply side will help in health system efficiency through their various inputs, such as public financial management, decentralization, accountability, policy and regulations, health promotion. But it is quite unfortunate to see that these aspects as the inputs are usually geared off just before the election time, and just to claim as a popular measure. That's really unfortunate and might break the sanctity of the health system. Hence, to whom it should be blamed, the academician. It is the right of the academician and the policymakers to cross check how far these machineries are actually diluting the system. So, since at the forefront at the political leader, and political leader is considered to be rich enough in all directions, so especially education really matters. Okay. So, hence we need to discuss about public financing management, decentralization, accountability, public regulations, patient rights, empowerment and health promotion. So, So, this leads to major impacts such as better quality, high quality, health behavior, financial protections, motivation of the health workers. Okay. On the demand front, it is the demand for health services is triggered mainly by three levels of the agents: community, family, and individuals. So and these will have also specific characteristics. It is bearing with socio demographic characteristics, individual factors, accessibility related factors, even it has dimensions to political characteristics and health security. Each level has different medical and non-medical expectations depending on their vivid characterizations or characteristics. So, all those things really matters. Each level has different medical and non-medical expectations. So, in the outcome we would have a better quality because it is cross checked with the demander side. So, medical expectation and non-medical expectations as part of the health system responsiveness are well addressed. So, what we have discussed about demand and supply for HSR, this will guarantee health literacy. Organizational health literacy is also important. Organizations where we mention about the supply side literacy aspect. Community health literacy also equally challenging and important, and very less number of paper you will find on this, especially in Indian context. I will suggest you to focus. We are actually working on it. My scholars are contributing hugely to this direction. So, I hope we have taken off all possible aspects on HSR, and so these are the readings which would further substantiate your understanding. So, that is all. Thank you for today. Expecting your presence next. Thank you.